Hello everyone, this is Dr. TSR. So today let us study about ovarian hyperstimulation syndrome. See, OHSS is a 5-mark question which will be asked in our theory exam. So you know it is one of the complication following IVF procedure or following ovarian stimulation because of excessive gonadotropin therapy which causes multiple follicle stimulation. It happens more with clomiphene citrate than with letrozole. Okay, so more common in assisted reproductive technology. So this is an introduction. So coming to the pathophysiology or etiology, what will happen? See, when there is increase in the level of HCG, that is from ongoing pregnancy plus the thing because of pregnancy HCG will come, and even you have given it as a trigger, right? So HCG is given as a trigger. So this HCG increases the expression of substances like VEGF. This VEGF, vascular endothelial growth factor, increases the vascular permeability. When there is permeability is increased, there is release of fluids and proteins, electrolytes from intravascular compartment to that of the extravascular space, which causes interstitial edema, right? So when there is loss of all these fluids, proteins, everything, there is hemoconcentration, hyperviscosity and hypercoagulability. Okay, and because of fluid collection there will be ascites and pleural effusion. This is pathophysiology. HCG, VEGF, hemoconcentration, hyperviscosity, hypercoagulability, ascites and hydrothorax. Coming to the risk factors for VHSS, that is young age, less than 35 years of age group, and thin. Remember, it is thin. Usually we study everything is complex with obese individuals, but here OHS is more common in thin individuals. Thin individuals, history of PCOS, where there are multiple number of follicles which are present already, and when you stimulate, still there will be more number of follicles, or more dominant follicles, hence OHSS. Then the estradiol level. See, they will ask in Viva what is the level of estradiol, which is responsible for OHSS. If it is ART cycle, if there is more than 4000 picogram per ml, or if it is following ovulation induction more than 1000 picogram per ml. So these are the two estradiol levels responsible for OHSS. Then use of HCG in luteal phase. If you want to maintain the pregnancy, use progesterone. Why do you want to use HCG? So because if you use HCG in luteal phase, again it is a risk factor. And if you are using GnRH agonist long protocol, because long protocol means continuous exposure to GnRH agonist is again a risk factor. And before doing any induction, if there is high AMH level, most common in case of PCOS or multiple level antral follicles, so there high AMH level, again more follicles will be stimulated. That's what multiple follicles is the risk factors for OHSS. So risk factors are, again I repeat, engage, thin body, history of PCOS, increase in the level of AMH, increase in the level of antral follicle count, ART cycle E2 level 4000 picogram per ml, and normal ovulation induction 1700 picogram per ml, and using HCG as a maintenance in luteal phase and GnRH agonist long protocol. So these are the risk factors. So when you want to assess whether the lady is at risk for OHSS or not, then you will take the history, right? History means timing of the symptoms in relation to HCG induction, whether it is early OHSS or late OHSS. When the late OHSS which occurs after many days is more severe. Okay. So then type of trigger, whether they have used HCG as a trigger or GnRH agonist as a trigger. And what is the level of estradiol E2 at the day of trigger. And then how many oocytes are retrieved for ART cycle, and how many embryos are transferred, and whether she had any history of PCOS. These are the histories which is related to OHSS. Coming to symptoms and signs, so patient usually present with abdominal pain which is prominent because ovaries are getting enlarged. The ovarian cyst is getting enlarged. So there is pain and there is ascites, abdominal distension. And since because of this pain, distension, the patient presents with nausea, vomiting, then pleural effusion, dyspnea, there is rapid weight gain, and finally when there is hemoconcentration, hypovolemia, there will be oliguria, generalized edema, pleural effusion and pulmonary edema. So investigation is, you have to record the weight of the mother daily and abdominal circumference, what is the HB, platelet and WBC count. So you have to look for hematocrit for raised hematocrit and do APTT for coagulation profile. Oliguria, renal function test, and then hepatic function test, serum electrolytes, because there is effusion, everything, third space fluid loss, and do ultrasound for confirmation of ascites and ovarian size, enlargement and multiple follicles to see. Then X-ray chest to look for pleural effusion and do intake output chart, because I told there is oliguria and urine pregnancy test, and then central venous pressure monitoring. So when it comes to classification, we have four types of classification: mild OHS, moderate OHSs, and severe OHSs, and critical OHSs. So mild OHSs means there is just abdominal bloating, nausea, vomiting, and size of the ovary is less than 8 cm. Whereas moderate, there will be vomiting plus there is ultrasound evidence of ascites, and size of the ovary is 8 to 12, and WBC count is still normal. In severe OHSs, WBC count is increased, size of the ovary is more than 12 cm, there is massive ascites hydrothorax, serum creatinine is between 1 to 1.5 mg per dl, clearance of creatinine more than 50 ml per minute, there is liver dysfunction, anasarca, hematocrit more than 45%. In critical OHSs, there is 10 ascites, hypoxia, pericardial effusion, serum creatinine more than 1.5 mg per dl, and clearance of creatinine less than 50 ml per minute. There is renal failure, thromboembolic events, ARDS. So remember, ARDS and thromboembolic events all comes under critical OHSs, and hematocrit is more than 55% and WBC is more than 25,000 per mm cube. This is about severity of OHSs. So if OHSs happens, how you should prevent? This also they will ask us in Viva question. How do you prevent OHSs? First you take the history, whether the lady is a case of PCOS or not, or there was any history of OHSs in the previous pregnancy. Then use appropriate stimulation protocol, not like GnRH long agonist long protocol. Use preferentially clomiphene citrate or letrozole or clomiphene plus GnRH agonist, so that mere influence of GnRH agonist for a long time is reduced. Okay, and you take metformin for 5 weeks. Prior, in case of PCOS patient, you want to induce. Next thing is, don't use HCG as a trigger, because you know already pregnancy, again there will be HCG, and you have given exogenous HCG. Both will add together, both will add up. So don't use HCG as trigger if more than 20 follicles are observed on the ultrasound. Instead of HCG trigger, you can use GnRH agonist trigger. And before putting the trigger, check for E2 levels. E2 level more than 3000 picogram per ml, please don't do. More than 20 follicles, again don't do. Use GnRH agonist as a trigger, instead HCG as a trigger. And again, when you want to support the luteal phase, don't use HCG for the luteal phase support. Use progesterone for the luteal phase support. And use, as I told, instead of GnRH agonist protocol, use antagonist protocol. Okay, and you, as I told, there will be third space fluid loss, there is loss of proteins, everything. So use plasma expanders like albumin 25% infusion, which comes in 100 ml bottle. So while you are with retrieving the oocytes, during the retrieval and even after the retrieval, use this. Then there is something called coasting. Coasting is a very important MCQ question, and also they will ask what is coasting in case of OHSs. Coasting means you withhold the gonadotropin FSH for 1 or more days prior to the HCG trigger. You give a gap for GnRH agonist or gonadotropins, you give a gap, that is gonadotropins. Okay, then you can use cabergoline or dopamine agonist, that is 0.5 mg from the day of HCG trigger for up to 8 days. Okay, that will also reduce the OHS, because it has its effect over the VEGF. That's what they say. So cabergoline 0.5 mg, you can give it for 8 days from the day of HCG trigger. Still, you can't prevent. So that happened, the OHS is there. Just you do cryopreservation of the embryos and don't transfer the embryo. You freeze all the embryo and cancel the cycle. Okay, that's what you retrieve the oocyte, but don't transfer the embryo. That is cryopreservation of all the embryos. So, which can prevent the late onset OHSs. These are some of the 11 points to tell how I can prevent OHSs. So, when they ask how do you prevent OHSs, at least this 10 points has to be there in the tip of mouth. Next, treatment of OHSs. So, as I already told, classification mild, moderate, severe and critical. So, from mild to moderate, you can treat OP basis, and severe and critical, you have to treat IP basis. So, main thing is there is fluid loss, so you have to hydrate the mother. So dehydration should not be there. Hydrate the mother. At least 1 liter of electrolyte balanced fluid per day, and not more exercise and sexual activity, because ovaries are already enlarged, they can rupture at any time. And do, uh, so do avoid NSAIDs, because already there is hypovolemia and there is oliguria started, there is renal shutdown is started. So if you use NSAID, which causes vasoconstriction again, afferent arterioles, so don't use paracetamol and all. So avoid NSAIDs as much as possible. And if there is so much of ascites causing respiratory difficulty and all, do abdominal paracentesis. And daily weight chart has to be maintained, and investigations has to be done. Look for renal function test, look for liver function test, and you have to assess the woman every 2 to 3 days. So if she can't be managed OP basis, she is not regular for follow-up, do admit the patient. There is no problem in admitting, do admit the patient and do follow-up. So that's about just mild and moderate. If it is severe na, you have to give IV fluids, 100 to 150 ml of crystalloid solution. NS or DNS is given, and 25% albumin also has to be given, 100 gram of 25% albumin. And strict input output chart has to be taken. Don't give diuretics, because already she is in hypovolemia. If you give diuretics, again intravascular compartment volume will reduce. Okay, so diuretics has to be avoided. And daily monitoring of body weight and abdominal girth has to be maintained, because abdominal girth for ascites, and body weight because she is filled up with the fluid, so she will gain the weight. So you have to monitor the body weight and monitor the full blood count to look for WBC increased, hematocrit, serum electrolytes, liver and renal function test. And then do paracentesis. If there is so much of ascitic fluids, 1 to 2 liters of fluid can be removed transabdominally. Again, don't remove fluid at a sudden. It has to be very slow and over at least 2 hours, over 2 hours. In patients with severe abdominal distension causing pain and breathlessness, and giving thromboprophylaxis, like to prevent thromboembolic events, you have to give low molecular weight heparin. And still, if there is any rupture of the ovarian cyst, or there the adnexa undergone torsion, there is torsion of the ovarian cyst, then you have to take for surgical treatment. This is in brief about ovarian hyperstimulation syndrome. So it is very important for university exam, and it will be asked for 10 marks as well as for our daily practice also. So you should know what trigger I should give, and what luteal phase support is best, and what should be the minimum estrogen level, and at what above the what level I am not supposed to trigger the case. What is called coasting, that is with withholding of gonadotropins, that is FSH, and what is called freezing the embryo and then cancelling the cycle. So this is all about OHSS. Kindly do subscribe to my channels. This is me, Dr. TSR. Kindly subscribe to channel for more such videos. Thank you.